What does a right to health care include? System-relative entitlements. By making the right to health care a special case of rights to equality of opportunity, we arrive at a reasonable, albeit incomplete and imperfect way of restricting its scope while still recognizing its importance. The account does not give individuals a basic right to have all of their health care needs met. At the same time, there are social obligations to design a healthcare system that protects opportunity through an appropriate set of healthcare services. If social obligations to provide appropriate health care are not met, then individuals are definitely wronged. For example, if people are denied access because of discrimination or inability to pay to a basic tier of services adequate to protect normal functioning, injustice is done to them. If the basic tier available to people omits important categories of services without consideration of their effects on normal functioning, for example, whole categories of mental health or long-term care or preventative services, their rights are violated. Still, not every medical need gives rise to an entitlement to services. The scope and limits of rights to health care, that is, the entitlements they actually carry with them, will be relative to certain facts about a given system, healthcare system. For example, a healthcare system can protect opportunity only within the limits imposed by resource scarcity and technological development within a society, that is, availability of resources. We cannot make a direct inference from the fact that an individual has a right to health care to the conclusion that this person is entitled to some specific health care service, even if the service would meet a health care need. Rather, the individual is entitled to a specific service only if, in the light of facts about a society's technological capabilities and resource limitations, it should be part of a system that appropriately protects fair equality of opportunity. The equal opportunity account of a right to health care, like the utilitarian account, makes entitlements to health care system relative. Effective treatment of disease and disability. The health care we have strongest claim to is care that effectively promotes normal functioning by reducing the impact of disease and disability, and thus protecting the range of opportunities that would otherwise be open to us. Just what counts as effective, however, and what should we do about hard cases on the boundary between treatment of disease or disability and enhancement of capabilities. It is a common feature of public and private insurance systems to limit care to treatments that are not experimental and have some proven effectiveness. Unfortunately, many services that count as standard treatment have little direct evidence about outcomes to support their use. They are often just customary treatment. Furthermore, it is often controversial just when new treatments or technologies should count as safe and efficacious, that is effective. What counts as reasonably effective is then a matter of judgment and depends on the kind of condition and the consequences of not correcting it. We might, for example, want to lower our standards for effectiveness when we face a treatment of last resort, or raise them if resource scarcity is very great. On the other hand, we do not owe people a chance to obtain miracles through whatever unproven procedures they prefer to try. By focusing a right to health care on the maintenance of normal functioning, a line is drawn between uses of medical technologies that count as legitimate treatments and those that we may want but which do not meet our health care needs. Although we may want medical services that can enhance our appearance, like cosmetic as opposed to reconstructive plastic surgery, or that can optimize our otherwise normal functioning, like some forms of counseling or some uses of Prozac, we do not truly need these services to maintain normal functioning. We are obligated to help others achieve normal functioning, but we do not owe each other whatever it takes to make us more beautiful or strong or completely happy. Though this line is widely used in both public and private insurance practices, it leaves us with hard cases. Some of the hardest issues involve reproductive technologies, abortion, where there is no preventative or therapeutic need, does not count as treatment because an unwanted pregnancy is not a disease or disability. Some nevertheless insist that requirements of justice include a right to control one's body, means that non-therapeutic abortion should be included as an entitlement in a healthcare system. Some national health insurance schemes do not cover infertility services, yet infertility is a departure from normal functioning, even if some people never want to have children. Controversy may remain about how much social obligation we have to correct this form of impaired opportunity, especially where the costs of some interventions, such as in vitro fertilization, are high and their effectiveness is modest. Different societies will judge this question differently, in part because they may place different values on the rearing of biologically related children or on the experience of childbearing. Hard cases involve non-reproductive technologies as well. In the United States, for example, many insurers will cover growth hormone treatment only for children deficient in a growth hormone, not for those who are equally short but without any pathology. Yet the children denied the therapy will suffer just as much as those who are eligible. Similar difficulties are involved in drawing a line between covered and non-covered uses of mental health services. As in the cases of reproductive technologies, there is room for different societies to construct the concept of mental disorder somewhat differently, with resulting variation in decisions about insurance coverage. Even when some healthcare service is reasonably effective at meeting a medical need, not all such needs are equally important. When a disease or disability has little impact on the range of opportunities open to someone, it is not as morally important to treat as other conditions that more seriously impair opportunity. The effect on opportunity thus gives us some guidance in thinking about resource allocation priorities. Unfortunately, the impact on our range of opportunities gives us only a crude and incomplete measure of the importance or priority we should give to a need or service. In making decisions about priorities for purposes of resource allocation in healthcare, we face difficult questions about distributive fairness that are not answered by this measure of importance. For example, we must sometimes make a choice between investing in a technology that delivers a significant benefit to few people or one that delivers more modest benefit to a larger number of people. Sometimes we must make a choice between investing in a service that helps the sickest, most impaired patients, or one that helps those whose functioning is less impaired. Sometimes we must decide between the fairness of giving a scarce resource to those who derive the largest benefit, or giving a broader range of people some chance at getting a benefit. In all of these cases, we lack clear principles for deciding how to make our choices, and the account of a right to health care we are discussing does not provide those principles either. Some methodologies, like cost-effectiveness analysis, are intended to help us make appropriate resource allocation decisions in these kinds of cases, but these methodologies may themselves embody controversial moral assumptions about distributive fairness. This means they cannot serve as decision procedures for making these choices and can at best serve as aids to decision makers who must be explicit about the moral reasoning that determines the distributive choices they make. In any healthcare system, then, some choices will have to be made by a fair, publicly accountable decision-making process. Just what constitutes a fair decision-making procedure for resolving moral disputes about healthcare entitlements is itself a matter of controversy. It is a problem that has been addressed little in the literature. Our rights are not violated, however, if the choices that are made through fair decision-making procedures turn out to be ones that do not happen to meet our personal needs, but instead meet needs of others that are judged more important. How equal must our rights to healthcare be? How equal must our rights to healthcare be? Specifically, must everyone receive exactly the same kinds of healthcare services and coverage, or is fairness in healthcare compatible with a tiered system? Around the world, even countries that offer universal health insurance differ in their answers to this question. In Canada and Norway, for example, no supplementary insurance is permitted. Everyone is served solely by the national health insurance schemes. The people who seek additional services or more rapid service may go elsewhere, as some Canadians do by crossing the border. In Britain, supplementary private insurance allows about 10% of the population to gain quicker access to services for which there is extensive queuing, that is, waiting in line, in the public system. Basing a right to health care on an obligation to protect equality of opportunity is compatible with these sorts of tiering the British have, but it does not require it, and it imposes some constraints on the kind of tiering allowed. The primary social obligation is to assure everyone access to a tier of services that effectively promotes normal functioning and thus protects equality of opportunity. Since healthcare is not the only important good, resources to be invested in the basic tier are appropriately and reasonably limited, for example, by democratic decisions about how much to invest in education or job training as opposed to healthcare. Because of their very high opportunity costs, there will be some beneficial medical services that it will be reasonable not to provide in the basic tier, or to provide only on a limited basis, for example with queuing. To say that these services have high opportunity costs means that providing them consumes resources that would produce greater health benefits and protect opportunity more if used in other ways. In a society that permits significant income and wealth inequalities, some people will want to buy coverage for these additional services. Why not let them? After all, we allow people to use their after-tax income and wealth as they see fit to pursue the quality of life and opportunities they prefer. The rich can buy special security systems for their homes, they can buy safer cars, they can buy private schooling for their children. Why not allow them to buy supplementary health care for their families? One objection to allowing a supplementary tier is that its existence might undermine the basic tier either economically or politically. It might attract better quality providers away from the basic tier or raise costs in the basic tier, reducing the ability of society to meet its social obligations. The supplementary tier might undermine political support for the basic tier, for example, by undercutting the social solidarity needed if people are to remain committed to protecting opportunity for all. These objections are serious, and where a supplementary tier undermines the basic tier in either way, economically or politically, priority must be given to protecting the basic tier. In principle, however, it seems possible to design a system in which the supplementary tier does not undermine the basic one. If that can be done, then a system that permits tiering avoids restricting liberty in ways that some find seriously objectionable. A second objection is not to tiering itself, but to the structure of inequality that results. Compare two scenarios. In one, most people are adequately covered by the basic tier, and only the best off groups in society have the means and see the need to pursue supplementary insurance. That is the case in Great Britain. In the other, the basic tier serves only the poorest groups in society, and most other people buy supplementary insurance. The Oregon plan to expand Medicaid eligibility, partly through rationing the services it covers, has aspects of this structure of inequality, since most people are covered by plans that avoid these restrictions. The first scenario seems preferable to the second on the grounds of fairness. In the second, the poorest groups can complain that they are left behind by others in society, even in the protection of their health. In the first, the majority has less grounds for reasonable resentment or regret. If the basic tier is not undermined by higher tiers, and if the structure of the inequality that results is not objectionable, then it is difficult to see why some tiering should not be allowed. But there is a basic conflict here between concerns about equality and concerns about liberty, between wanting to make sure that everyone is treated properly with regard to health care and wanting to give people the liberty to use their resources after tax to improve their lives as they see fit. In practice, the crucial constraint on the liberty we allow people seems to depend on the magnitude of the benefit available in the supplementary tier and unavailable in the basic tier. Highly visible forms of saving lives and improving function would be difficult to exclude from the basic tier while we make them available in a supplementary tier. In principle, however, some forms of tiering will not be unfair even when they involve medical benefits not available to everyone.